Hello,
este
good
webinar
morning.
sobre dolor
Good morning
lumbar.
to everyone, all those who
Vamos a
are
hablar
joining this
un
seminar
minuto
on
quizás
lumbar
mientras
pain or low
vayan
back
se van
pain.
uniendo todos los
We'll give a few
participantes.
minutes more as all the
Tenemos más de 1000
participants
personas
meet.
registradas para este
We have more
webinario,
than 1,000
lo cual
people
nos da un poco una idea
registered
de
for
la
this webinar. This
importancia
gives us an idea of
del
how
tema del cual
important
vamos a hablar hoy.
the
Así que
issue
muchísimas
is.
gracias
So
a
thank you
todos
very
los
much
participantes por
to
haberos
all
registrados.
the participants for having registered.
Mientras esperamos
While
a que se
we
una algún
wait till they
participante,
join,
os puedo indicar que justo abajo en
I
la
can
esquina de
tell
las
you that
pantallas
at the bottom of
tenéis
your
un chat box
screen,
donde
you have a
podéis
chat
saludar,
box.
podéis decir
You
desde
can say
dónde conectáis si
hi, you
queréis
can
o
say
tan
where you
solo para
connect from if
preguntáis.
you wish, what organization you work
Después
for.
tenéis un Q&A
Then you
box, una
also
casilla
have
de preguntas y respuestas
then you also have a
delante de ella
QA
y tenéis
box
oportunidad,
where
pues
you
podéis escribir aquellas
can
preguntas
write
que
any
os surjan
questions
a lo
you
largo del
have
webinario respecto
along
a lo
the
que
webinar
se va a hablar hoy
concerning
en el
the
webinario dolor lumbar,
topic of today.
¿de acuerdo? Y justo también a la derecha tenéis un botón, un icono
And on the
del
right,
mundo
you
de
have
programación,
a
porque este
global
webinario está
symbol
disponible en
because
inglés
this
y en
webinar
español.
is available in English and
Así que
Spanish.
podéis
So you
utilizarlo a
can
vuestra
choose
conveniencia. Va a haber
the language
exposiciones
you
en
prefer
español,
there.
va a haber
There
también
will be
exposiciones en inglés
presentations in Spanish,
y al final
presentations
tendremos
in
también un
English,
periodo
and
para
at the end,
preguntas y
we'll have a
respuestas.
question for, I'm sorry, period for questions and answers.
Buenos días a todos desde Colombia, Surinam,
Morning,
Guatemala.
everybody from Colombia,
Podría
Suriname,
ver también gente de
Guatemala.
México.
I'm so glad to see
Muchísimas
so
gracias
many
por
people
uniros a este
from
webinario.
Mexico. Thank you very much
Bueno,
for
no me he
joining
presentado.
this
Yo soy
seminar. I
Gustavo
haven't
Pérez
introduced
y
myself. My
soy el
name is
asesor
Gustavo
regional
Perez.
para
I'm the
discapacidad y
Regional Advisor
rehabilitación de
for
la Organización
Disability and
Panamericana de la Salud
Rehabilitation of the
y junto
uh,
con la
Pan
Universidad de
American Health
Ontario Tech, el
Organization, and
Instituto de
together with
Investigación en
Ontario Tech,
Rehabilitación y
the
Discapacidad,
uh,
hemos
and
organizado
their
este webinario
Institute
para
of
hablar del dolor lumbar.
Research
Bienvenidos a
on
Valencia, Bogotá. Un placer teneros aquí a todos, a todas.
Disability and Rehabilitation. We have organized this seminar
Honduras, buenos días.
uh,
Bueno,
from
pues
Honduras.
pasados ya
Good
dos
morning.
minutos desde las 11, creo que ya
So two
podemos dar
minutes after
comienzo
11, I
al
think we
webinario
can
y voy a
start the
ceder el
webinar.
micrófono
And
a
I'll pass
Silvana
the
Luciani,
floor
que es la
to
jefa de la
Silvana
Unidad de
Luciani,
Enfermedades
who
No
heads
Transmisibles de
the
la Organización Panamericana de la
non-communicable
Salud para dar
disease
palabras de bienvenida. Adelante,
division
Silvana, la
at
mesa es
PAHO
para ti.
for her
Muchas
welcoming
gracias,
remarks. Silvana,
Gustavo, y
thank
muy
you very much,
bienvenidos a todas y a
Gustavo.
todas a
Welcome to
nuestro
you
webinar.
all
Soy
to
Silvana
our
Luciani, la
webinar.
jefa
My
de la
name is
Unidad de
Luciana
Enfermedades
Luciana.
No
I head
Transmisibles,
the
donde está ubicado el
non-communicable
programa de
disease
rehabilitación y
division, where the
discapacidades.
Rehabilitation and
Y voy a dar
Disability
mis palabras de
program
bienvenida en inglés,
is
pero como Gustavo mencionaba, tenemos
I'll speak
traducción
in
al
English, but
simultáneo.
as was mentioned, we have
Welcome
simultaneous
and warm greetings
interpreting.
from PAHO in
Uh,
Washington, D.C. It's a pleasure for me to welcome you all to our webinar on low back pain. And it gives me great pleasure to be co-hosting this together with Ontario Tech University, a WHO collaborating center on disabilities and rehabilitation. And together we're thrilled to have you join us to learn today about our new data, new information, new treatment recommendations, and new perspectives on how to address this very common yet debilitating chronic condition of low back pain. And, we've titled this webinar, Why Should We Care About Low Back Pain? And we want to highlight the many, many reasons why we should all care about low back pain. First and foremost is just the sheer magnitude of the problem. There's an extraordinary number of people suffering in pain, affecting their mobility and functioning and quality of life. And many of you who are connected here today may also be suffering from low back pain or have experienced it in the past or have loved ones who are experiencing low back pain. Worldwide, we know over 600 million people have chronic low back pain. And with a growing population and an aging population, and with rises in NCDs, we know that this number of people will increase dramatically to over 800 million people worldwide in the coming 25 years. And we also know that many social determinants of health, such as education, income, and your environmental factors, all have an impact on low back pain, which can increase the frequency and severity of low back pain. We also know that health systems are already overwhelmed with the need to build their capacity to be able to provide care and to provide rehabilitation services to such a large number of people. And of course, the healthcare needs will only increase with the increase in the prevalence of low back pain. So this calls attention to the need to really strengthen rehabilitation services now to ensure that adequate care and quality of care is provided to people who are suffering from low back pain, as well as to address the determinants of health to help reduce some of those disparities that are associated with low back pain. And so to achieve this, we're pleased to be able to share with you today in the webinar the recommendations and interventions to address low back pain. And this will include covering and reviewing the WHO guidelines for non-surgical management of chronic primary low back pain in adults in primary and community care settings, along with the WHO package of interventions for rehabilitation, focusing on the module for musculoskeletal conditions. But there's another reason we should all care about low back pain, and that's the increasing demand and pressure it puts on health services as a result of frequent hospitalizations or increased number of physician visits and ambulatory care. And the demand will only increase with the number of people increasing with low back pain, especially for workforce needs and needs for multidisciplinary teams, such as having more physical therapists, having more pain specialists, among others. And of course, this puts tremendous pressure on healthcare costs and strains health budgets in an environment where we know there's already very limited resources being devoted to health. And this brings me to the other reason why we should care for low back pain as public health professionals, the impact it has on economies. In the USA alone, for example, the direct costs of low back pain is about $9,000 per person per year. And this doesn't even include the indirect costs that are attributed to lost productivity, workplace absenteeism, and reduced workforce participation. So what we're calling attention to in this webinar today is not only the economic burden of low back pain and the high burden of low back pain, and the fact that it is the leading cause of disability in the world, but also the importance of prioritizing prevention strategies and having in place early interventions like physical activity and other non-pharmacological interventions. But unfortunately, as public health professionals, we're all too aware that public health priorities often don't include low back pain and health services for low back pain management. It's often underprioritized and it receives disproportionately lower global health funding. So today, we'd also like to talk about the need and importance of increasing investment in rehabilitation services, rehabilitation workforce, and multidisciplinary approaches to manage the growing problem of low back pain. So thank you everybody for your participation today in the webinar, and a special thank you to our colleagues at Ontario Tech University for collaborating with us. And we hope you're inspired to make changes to rehabilitation services as a result of today's webinar on low back pain. Thank you again, and over to you, Gustavo.
Thank you very much. Muchísimas gracias, Silvana, por tus palabras de bienvenida. Silvana ha
Thank you very
puesto un
much,
poco la idea de lo que
Silvana.
como
Welcoming words.
reflexión a nivel
Silvana
global, ¿no?
has
En este webinario
mentioned
vamos a tratar
what
de poner datos sobre lo que este
low back
dossier
pain
representa y
means, and
también
we'll put
junto con la
data to
Universidad de
this.
Ontario, que lo acaba de
Together with
mencionar Silvana,
Ontario
hablar un poco
University,
de la
well,
evidencia
we're
más
going to talk a
reciente
little bit
y
about the most
recomendaciones
recent
que
evidence and
se necesitan para tratar
recommendations
este
we
problema,
need
¿vale?
to
Además, durante el
treat, to
webinario
address this
se
low
abordarán
back pain.
experiencias de
During the
practicantes de
webinar, we'll have
rehabilitación
experiences
como
from
doctores y
rehab
personas que han sufrido dolor lumbar y
specialists
cómo
and
esta
people who
situación,
have
esta
suffered
condición de
low
salud
back pain
ha sido
and how
abordada desde
this
múltiples
health
ángulos.
condition has been
El vídeo
addressed
esta
in a
esta sesión va a
multidisciplinary
ser
way.
grabada y
This
como esta
session will
grabada
be
estará disponible en la
recorded and
página
it'll
web
be
del Centro
available
de Rehabilitación
in
de
the
la Universidad Católica de
disability
Salud.
and
Sin
rehabilitation
más dilación,
website at
voy a
PAHO.
compartir
With no more to say,
la
I'm going
pantalla
to share the screen with you
para ofrecer unos datos claves
just to offer
alrededor de lo que
some key
representa este
data
dolor lumbar,
around low back pain,
específicamente ya no solo en el dolor,
specifically
sino también en la
not
región de la cervical, ¿no?
globally,
Como ha
but
comentado ya
particularly in the
Silvana,
Americas. As Silvana
realmente el low back
commented,
es la
really low back
principal
pain
causa de
is the
discapacidad en el
main
mundo y
cause
por
for
lo tanto
disability
representa
in the
un
world. So
problema de
it
salud pública a nivel
counts
mundial.
for a
Y es
public
que
health
los
problem
costes
the
indirectos
world over.
relativos a la
Indirect
pérdida
costs
de
related to
productividad
productivity loss and
pueden llegar
disability
a
represent
representar actualmente entre el
approximately
80 y
80
el
to 90%
90%
of the
de la
total
carga
of
económica
economic
global.
burden.
Esto nos da una idea muy
This
seria
gives
de que
us
tenemos
a
que ser
very
capaces
serious
de lo que
idea
representa el
that we
dolor low
have
back y
to
cómo
be
puede ser
concerned
abordado.
about low back
Por
pain,
ejemplo, países
LBP,
como
and how
Brasil,
it can be
Argentina y
tackled
otros
with.
países en
Brazil,
Latinoamérica
Argentina, and other
están
countries in the
reportando unas
Americas
tasas de
report
hospitalización
hospitalization
por
rates
encima del
for
13% y que
LBP
pueden llegar
between
hasta casi el 19%,
13.4%
lo que
and
supone unos costes anuales de
18.7%,
billones de dólares.
with
Esta
billions of
gráfica es
annual
específica de la región de
billions
las
of
Américas
dollars in
y
annual
nos habla
care.
de aquellas condiciones
This
que
is
pueden
specifically to the
necesitar
Americas, and these are
rehabilitación y
conditions that
entre ellas
require
las más
rehabilitation,
importantes
among
son
which
la
the most
franja
important,
de entre
particularly
50 y
in
70
the
años,
tribe
son
between 50
precisamente
and
las
70 years
patologías
of
de
age,
origen
are
musculoesquelético.
pathologies of
Si bien es cierto que conforme
musculoskeletal
cumplimos años,
pathologies.
aparecen otro tipo de
As we
patologías que
age, other
también
pathologies appear
demandan
that also
rehabilitación, como
demand
pueden ser
rehabilitation,
patologías
such
neurológicas,
as
patologías
neurological
sensoriales, por
pathologies,
ejemplo, la pérdida
uh,
de audición o
loss
la
of
pérdida de
hearing,
visión.
or sight.
Dentro de las patologías musculoesqueléticas
Among
y también
musculoskeletal
particularmente en nuestra
pathologies, and
región de las
specifically in
Américas,
our region here in the
aparecen unos datos
Americas,
muy
we have
significativos.
very
Y es que
significant
realmente
data.
es el dolor
Really,
lumbar de nuevo
low
causado
back
en la
pain,
franja de edad entre los
again,
50 y
between
los 70
50
años,
and
la
70
que
years of
representa una
age,
mayor prevalencia de personas
accounts
que
for the
necesitan
greatest prevalence
rehabilitación.
of
Todos
people
estos
who need
datos son ofrecidos por
rehabilitation.
el Instituto de
All
Fenimetría de la
this
Universidad de
data is
Washington
offered by the
y son bastante claros
University
en lo
of
que representan esto.
Washington Institute
Realmente
of
luego, conforme
uh,
pasan los años, aparecen otro tipo de
rehabilitation.
desórdenes
Um,
o de patologías
there are
musculoesqueléticas,
other
como pueden ser las fracturas
disorders and
o la
pathologies as
osteoartritis.
fractures or
Aquí
osteoarthritis
vemos, en esta
arthritis that
comparativa
comes
entre hombres y
later
mujeres,
on.
por ejemplo, en el
And
sexo
if we compare
femenino,
between
también en la
men
región de las
and
Américas,
women in the
vemos como esta
Americas, we see
prevalencia
how this
está por encima de
prevalence
las 20.000 personas
is
por cada
above
100.000,
20,000 people
cuando en el
per
sexo masculino, también
100,000
en la región de
people
las Américas, esta
among
proporción no llega
men.
al 20, siendo
And
en torno
this,
a 18.000 por cada 100.000. Esto nos habla de que
among
el dolor
women,
lumbar
sorry, and
tiene
this
género y tiene rostro de
uh,
mujer
is
principalmente,
18.
y
It
sobre
is
todo en esta
mainly
franja de edad que hemos
for
comentado,
women,
entre los
particularly
50 y los
in
70
this
años.
age bracket between
Realmente
50
son
and
muchos los
70.
factores los que
Really, there are
intervienen en el
many
dolor lumbar
factors
y estos
that
factores nos pueden llevar
intervene
de
in low back
factores
pain. They
socioeconómicos,
can be
de la edad,
socioeconomic factors,
del tipo de trabajo que
age,
desempeñamos,
the kind of work
pero
we
aún así
do,
sabemos que en la
but
región de las
even
Américas,
like
que es en
that,
el
we
norte de
know
América,
that
Canadá, México, Estados
North
Unidos, donde
America,
aparece
Canada, Mexico, and
una
the
mayor
United
prevalencia del
States
dolor lumbar,
have
a
more
pesar de
prevalence
las
of
posibles
low back
inconsistencias
pain.
metodológicas
Despite
que puedan existir por la
methodological
recogida de datos.
inconsistencies we can
Sabemos
have
que esto
in data collection, we know
representa en
that
todo el
this
continente una grave amenaza a
represents
nivel de salud
a
pública, de tal
large
manera que el
threat
dolor
of public
lumbar
health
crónico
all over the
puede afectar de
continent.
entre un 10
So
a casi un
chronic
20%
LBP
en la
can
población
affect
entre
from
20
10
y 60 años en todo
to
el mundo.
20% in the population
Esta
between
gráfica es
20
bastante
and 60
importante
years
porque nos revela
globally.
cuáles son los
This is an important
determinantes
graph telling
sociodemográficos del
us
dolor
what are the
lumbar. Es decir,
social
le tenemos que poner
demographic
rostro al dolor
determinants
lumbar
of
para identificar
LBP.
cuáles son
So we
las
have to put
condiciones
a
que lo
face
producen.
to LBP to
En
know
cuanto al sexo y al
what
género,
causes it.
sabemos que en el
Concerning
género
sex
femenino
and
hay
gender, we
mayor
know that
probabilidad de
among
buscar
women there
atención de
is
un
a
profesional
greater
de la salud,
probability
mientras
of
que en el sexo
looking for
masculino hay mayor
health care.
probabilidad de buscar
In
la
men,
confirmación de
it's
ese dolor a través de
mainly
una prueba de imagen.
confirming that health through an
En cuanto al
image
estatus
test.
socioeconómico, también
Concerning
tiene color y
socioeconomic
tiene forma y otra
status,
forma
it
de
also
pobreza. Es
has
decir,
color
cuanto
and
más bajo sea
shape.
el nivel socioeconómico,
Poverty. The
más
lower
altas
the
son las probabilidades de sufrir
socioeconomic
dolor lumbar
level, the
y más
higher
alta son las
possibilities
probabilidades
of
de acudir a
LBP,
una
and the
prueba
higher
de
the
imagen que muchas
probabilities
veces
of
son
going to an
innecesarias en
image
nuestras
test
horas
that
y también de
oftentimes
recibir
are
tratamiento farmacológico de tipo químico.
unnecessary, and also
En cuanto a la raza y la étnica,
receiving
de nuevo
opioid
también el dolor
treatment.
lumbar tiene color,
Concerning sex and
es
gender,
entre la
again,
población blanca no hispana
color.
la que tiene
Among
mayor
whites and
probabilidad de ser
non-Hispanic,
prescrito con terapia
they are
farmacológica o
mostly
también de
prescribed
recibir
with
recomendación
pharmacological
acerca de una
therapies or
cirugía para el
receiving
dolor lumbar, lo
recommendations
cual en muchos
about
casos no
surgery
está indicado.
for LBP.
También
In
es esta
many cases,
población
that's
blanca
not
no hispana
indicated.
la que puede
And
recibir un tratamiento
those who
adecuado a
can
las guías de
receive
práctica clínica.
appropriate treatment
Y en cuanto a la edad y el uso
according to
oncológico,
the clinical practice
sabemos también
guidelines.
que con el aumento de la
And
edad
In
también en el
concerning
ambiente de los
socioeconomic
requerimientos o las
status,
preferencias
I'm
de
sorry,
personal
age,
a un
we know
centro de
that
salud
with
o a un
age,
hospital
you have more
para
people
abordar
coming
este
to
dolor.
a health center and
En cuanto a
hospital
los
to
factores, vamos a
tackle with
mencionarlos
their LBP
brevemente.
factors
El principal y
briefly.
más importante de todos
The
es
main
el
and
factor de
most
ocupacional
important is
ergonómico, es decir,
occupational ergonomic
prácticamente todos los que
factors.
estamos sentados hoy aquí
Practically all
escuchando
those
este
who are
webinario hemos
sitting
sufrido
here
dolor
listening to
lumbar,
this
¿no? Y sabemos
webinar
que
have
el pasar muchas horas
suffered
sentado provoca una
from
larga dolor lumbar.
LBP
Y este
because we sit
efectivamente es
for
el
long
factor líder que
hours.
contribuye
That's a
al
leading
número de
factor
años
contributing
vivido con
to the number
discapacidad,
of years
llegando a ocupar hasta un
lived with
22%,
disability
¿no?
up to
Por eso muchas veces se
22%.
recomienda no
This
pasar
is
más de
why we
45 minutos,
recommend
por ejemplo,
not
sentado
to have more
enfrente
than
de una pantalla.
45 minutes sitting in
El
front of
alto
the
índice de masa
screen.
corporal sabemos que
High
está detrás
body
de muchas
mass
patologías
index,
de
it's
tipo
behind
crónico,
many
¿no? Tanto por
pathologies today,
lo que genera a
chronic
nivel
pathologies,
metabólico como
because
a
of
nivel
what it
mecánico, ¿no?
generates
Sobre todo en
metabolically and
mujeres
also
de mediana edad
mechanically,
hasta fines de
particularly
30
in
años.
women
El tabaco igual, también está
after
detrás de
50 years
muchísimas
of age.
patologías y sabemos que
Smoking
puede
is
contribuir hasta
behind
un
many
12,5%
pathologies. It can
de la carga
contribute up
en
to
cuanto a la prevalencia de
12.5% of
discapacidad
burden
generada por
in
dolor lumbar.
disabilities
De
due
nuevo lo hemos
to
pasado
low
anteriormente, el
back
dolor
pain.
lumbar
A
tiene
low
edad
back
y tiene
pain
sexo,
has
tiene
an
género,
age and
tiene
sex.
rostro de mujer y una mujer entre
It
los
has
50 y los
a
69
woman's
años,
face,
aunque
a
también puede
woman
estar
between
presente
50 and
hasta los
69
80 y
years of
85
age,
años. Por
but
eso
it can be
vemos que es
present
muy
up to
importante
80
este
and
enfoque de
85 years
género
of age.
para
So
tratar el dolor
this
lumbar,
gender
teniendo en
approach
cuenta
is
esta
very
evolución
important to
biológica.
deal with LBP.
También, como hemos comentado anteriormente,
Also, as we have
estos son
commented,
psicosociales,
psychosocial and
son
socioeconomic factors
importantísimos.
are
La soledad,
extremely
el
important.
aislamiento, la pobreza,
Loneliness,
también son
isolation,
factores que
poverty
pueden
are also
influir
factors
sobre
that
la
can
prevalencia
impact
de dolor
prevalence
lumbar.
of LBP.
Otros factores importantes que
Other
podemos
important factors
encontrar son
that we can
una
find
postura pobre
are
mantenida
poor
durante el
posture
trabajo o una
at
debilidad
work,
muscular o
core
un trauma
muscles,
mecánico
muscle
repetitivo, es decir,
weakness,
posturas
repetitive
mantenidas
stress
durante
injuries,
muchísimo
and
tiempo
injuries
o crear
sustained both
alarma,
at work and
ambas
home
son factores
environments.
que
These
contribuyen
are
al
common
dolor lumbar.
contributors to mechanical
Todos estos
LBP.
factores que acabo
All
de
these
mencionar
factors I just
están aquí en esta
mentioned
gráfica muy
are
bien
here in
explicados,
this
¿no? Es
graph. They
decir,
are very
son
well
factores que están
explained. These are
tremendamente
factors that
correlacionados
are
y no
tremendously
podemos aislar
correlated,
un
and
factor
we can't
social de un factor
isolate a social
genético o
factor from
biológico
a
de un factor
genetic factor,
psicológico.
from a
De tal manera
biological
que los
factor,
factores
from a
biológicos,
psychological
como por
factor.
ejemplo pueden
So
ser una
biology,
mala
it
mecánica
can be
lumbar o
bad
una carga
low back
excesiva,
pain, low
pueden
back
provocar también
mechanic
una
or
alteración
excessive
por una
burden,
interpretación
or
errónea del dolor,
also
lo que
an
llamamos
alteration
la
because
empresa de
of
rehabilitación la
mistaken
sensibilización
interpretation of
central, ¿no? Es
pain.
decir, un
That
dolor
is
no
central
bien procesado. También
sensitivity,
tenemos
pain that
otros
is not
factores
well
sociales,
processed.
como pueden ser
Also,
las
social
relaciones
factors
familiares, las
such as
relaciones entre
family
pares, cuáles son las
relations
circunstancias que uno
among
vive en la
peers.
familia.
What are the
Y por
circumstances we have
último,
in our
los
families?
factores psicológicos que
And
también
family
influyen en la
psychological
prevalencia del
factors that
dolor lumbar.
also
Puede ser la
impact a
depresión o la
prevalence of
kinesiofobia, ¿no? Es decir,
LBP.
el
It
tener
can
miedo
be
al
depression
movimiento,
or
creyendo que
kinesiophobia,
el
that you
movimiento me va
don't
a
like to
generar más
move
dolor, ¿no?
because
Todos
you
estos
think that
factores
moving will generate
interactúan
more
entre
pain,
sí,
and that's
son el
wrong.
caldo de
All
cultivo
these
para provocar un
factors
dolor lumbar y mantenerlo
are
en descenso.
behind
Por eso
causing
es tan importante
a
desde el
chronic
DRS,
low back
hacemos
pain.
énfasis
And that's
especial
why it's
en
so
el
important. And
tratamiento
at PAHO,
multidisciplinario
we
para abordar
emphasize
el dolor lumbar, de
multidisciplinary
tal manera
treatment
que
to
puede
tackle
contener
with low back
intervenciones de
pain.
tipo
So
psicológica
you
para
can have
mejorar tu entorno,
psychological
para mejorar tu
interventions to
autoestima,
improve
para
your
mejorar cómo te
environment,
relacionas,
self-esteem, how you
incluso
relate
la
to others,
propia percepción
even
que
your
tienes
own
del dolor.
perception
También,
of
por supuesto, un
pain.
tratamiento de
Also,
rehabilitación basado
a
principalmente en ejercicios
rehabilitation
terapéuticos
treatment
y una
based
serie de
on
terapias que luego nos
therapeutical
comentará nuestro
exercises and
colega de la
therapies that
Universidad
will
de
be
Ontario.
commented
Y
by our
todo
friends
esto
from
hace que
Ontario University.
mejoremos
And
la
all
tolerancia
this
al dolor para
helps
nuestras
us
actividades de la vida
with
diaria y para
increased
que nos
tolerance towards
procure mejorar
pain in
nuestra
our daily
participación en
activities,
nuestro entorno, en nuestra vida
improving our
familiar, en nuestro
participation in
trabajo
our
y demás.
environment, family life,
Bueno,
work,
pues
etc.
con esta
Well,
presentación alrededor de
having
los
said
datos,
this,
a
around
continuación
data,
vamos a
we
pasar
now
a un
pass
momento del webinario. Es
to
un
a
periodo que
moment
hemos
in the
pregrabado
webinar
junto con los
that we
colegas
have
de la
pre-recorded
Universidad de
together with
Ontario,
our colleagues at
donde, como hemos dicho,
Ontario
vamos a
University. As
exponer
I have said, we're going
cuáles
to
son o cuál
talk
es la evidencia más
about
reciente que se
the
aconseja
most
para el
recent
manejo del dolor
evidence
lumbar
that
y
is
una serie
recommended for managing low
de
back pain,
testimonios
and a
tanto de
number
profesionales de la
of
rehabilitación como
testimonies
también de pacientes
of
que han estado en este
rehabilitation professionals and of patients who have experienced low back pain and how it has been addressed. So with no more to say, we're going to the recorded section in this webinar. Go ahead, please.
As a World Health Organization collaborating center on rehabilitation and musculoskeletal health at the Institute for Disability and Rehabilitation Research at Ontario Tech University in Canada, we acknowledge the Indigenous lands that we are grateful to live, work, and play on. The lands that we are situated on are covered under the Williams Treaties and are of the traditional territory of the Mississaugas, a branch of the Greater Anishinaabe Nation, including Algonquin, Ojibwe, Odawa, and Potawatomi. These lands remain home to a number of Indigenous nations and people. We acknowledge the many Indigenous peoples who have cared for the land, the water, and the biodiversity of Turtle Island, also called North America, from before the arrival of settler peoples until this day. We invite you to consider the ancestral lands that you were situated on and the stewardship of Indigenous peoples across North and South America.
A continuación, vamos a escuchar a Pierre Coté, que es el director del Centro Colaborador de la OMS, el Instituto de
Now we will
Investigación
listen to Pierre
en
Coté,
Rehabilitación y
who
Discapacidad
does
de la
research on
Universidad de Ontario
rehabilitation
de Canadá.
and discapacity at Ontario Tech in Canada. Go ahead, please.
Hello, my name is Pierre Coté.
Hola,
I
mi
am
nombre
a
es Pierre
professor of
Coté, soy profesor de
epidemiology and director
epidemiología y
of the
director
WHO Collaborative
del
Center
Centro
for
de Colaboración de la
Rehabilitation and
OMS para la
Musculoskeletal
rehabilitación de la
Health
salud
at the Institute for
musculoesquelética en el
Disability and
Instituto para la
Rehabilitation
Investigación
Research
sobre
at
Discapacidad y
Ontario Tech
Rehabilitación de la
University.
Universidad Tecnológica de Ontario.
Rehabilitation is a global
La
need.
rehabilitación
Right
es
now,
una
more
necesidad
than
global.
2.6 billion people could
Actualmente
benefit
más
from it.
de
In
2.600 millones de
particular,
personas podrían
musculoskeletal
beneficiarse de
conditions
esta
alone
particular
affect over
trastornos
1.7 billion people.
musculoesqueléticos.
Conditions
Ellos
such as arthritis and
afectan
back
a más de
pain that impact the
1.700
quality
millones
of
de
life
personas
and
con
workability of the
trastornos como la
population.
artritis y
In low back pain specifically is
el
now the
dolor de
single
espalda que
leading
impactan la
cause
calidad de
of years
vida
lived with
y el trabajo de la
disability in
población.
160
Y
countries
ese dolor
worldwide.
es ahora la causa más
These numbers show that
importante
rehabilitation
de
is
vivir
not
con
It's
discapacidad.
essential for addressing one of the most common and disabling health challenges all over the world. In 2019, across the Americas, there were 366 million people with health conditions that could benefit from rehabilitation. And this number has increased by 58% since 1990. Importantly, the increase was higher in women than in men. Low back pain is the single largest contributor to years lived with disability in the Americas, ahead of depression, anxiety, and diabetes. And as people get older, the likelihood of having low back pain raises sharply. So for policy and health systems planning, low back pain represents a major and growing need for investment in prevention, early management, and access to rehabilitation, which are essential to reduce its disability burden. Low back pain typically starts in adolescence around age 15, and its prevalence increases with age, peaking in older adults. For most people, it is short-lived, but for about 1 in 3 or a third, symptoms can persist for up to a year and become chronic. When back pain becomes chronic, it has serious consequences. It is linked to poverty, early exit from the workforce, and is more common among people with lower socioeconomic status. At the same time, healthcare costs are rising sharply, often driven by low-value care that doesn't improve functioning or other health outcomes. What we know works best for the management of low back pain is a multidisciplinary biopsychosocial approach that combines physical activity, exercise, and psychological support. These interventions have been shown to improve functioning and positively impact health. You will hear a bit later about the best treatments to manage chronic back pain. However, there are things that can be done to reduce the likelihood of chronicity in people with acute back problems. For clinicians, these include avoiding opioids, not prescribing paracetamol, only using x-rays, CT scan, or MRIs when you detect a red flag or suspect a serious pathology, promoting self-management and return to activities, and limiting the use of passive treatments such as stents, braces, ultrasound, or traction. At the system levels, it is important to prioritize the implementation of evidence-based rehabilitation care pathways, particularly in primary care settings. These care pathways should avoid the unnecessary use of drugs or surgery. So we have an opportunity in the Americas. Not only is low back pain the main cause of years lived with disability, it is also the main condition amenable to rehabilitation in our region. Investing in the evidence-based rehabilitation of low back pain is investing in the health of our population.
Hello, I'm Carol Cancelier at the WHO Collaborating Center for Rehabilitation and Musculoskeletal Health at the Institute for Disability and Rehabilitation Research, Ontario Tech University. Low back pain is defined by the World Health Organization as pain, muscle tension, or stiffness that is localized below the costal margin and above the inferior gluteal folds. It may or may not include leg pain. When we talk about chronic primary low back pain, we mean pain that has persisted for at least 3 months without an identifiable specific cause, such as cancer, infection, or fracture. It's important to recognize that low back pain is often multifactorial, influenced by physical issues like poor posture or weak muscles, psychological factors such as anxiety or depression, and social factors like stressful work conditions or lack of social support. Globally, low back pain is one of the leading causes of disability, and it affects quality of life, daily functioning, and productivity in every region of the world. In low-resource settings, the impact can be even greater because many people have limited access to early assessment and rehabilitation. Person-centered care means designing treatment around the unique needs, values, and preferences of each individual. This approach invites the patient to be an active partner in their care, using shared decision-making to select strategies that fit their goals and daily realities. Because low back pain has physical, psychological, and social dimensions, care must address all three. For example, physical therapies and exercise can improve mobility, while psychological support can reduce fear of movement, and social support can help with returning to work or daily activities. In low-resource environments, psychological and social support may come from community structures, family networks, and peer groups rather than formal mental health services. Equity must be addressed. Care should be affordable, culturally relevant, and accessible to all, particularly for those in rural, remote, or underserved areas. When patients feel understood and involved in their care, adherence improves, satisfaction increases, and outcomes are better. The WHO guideline outlines several interventions for the non-surgical management of chronic primary low back pain in primary and community care. First, provide education, accurate, evidence-based information about low back pain and self-management. Education can help people stay active and avoid unnecessary fear. This can be delivered through conversations, group sessions, posters, or radio programs, depending on what's feasible locally. Second, encourage exercise programs tailored to the individual's capacity and preferences. This could include walking, stretching, body weight strengthening, or yoga, depending on what's available and acceptable locally. These activities require no equipment and can be done at home or in community spaces. Third, where trained providers and safe facilities exist, consider integrating physical therapies such as spinal manipulation, massage, or mobilization. These should complement, not replace, core low-cost strategies. In settings without access to these therapies, the focus should remain on interventions that can be delivered effectively by primary care or community health workers. Fourth, where available, incorporate psychological therapy such as cognitive behavioral therapy. In settings without mental health professionals, adapted approaches like peer-led support groups, community workshops, or basic psychosocial skills training for health workers can help address the emotional aspects of pain. Finally, use medications cautiously. NSAIDs can be considered for short-term relief when available and affordable, but opioids should be avoided for routine care because the risks outweigh the benefits. In low-resource settings, over-reliance on medicines can also lead to unnecessary costs. WHO advises against routinely offering these interventions for chronic primary low back pain in primary or community care. Lumbar braces, belts, or supports, as they don't improve long-term outcomes and can weaken muscles. Traction therapies are not supported by evidence and can waste scarce resources. Opioids carry a high risk of dependence, side effects, and cost without meaningful benefit. Invasive procedures or surgery are not effective for this type of back pain in these care settings, and they expose patients to unnecessary risk. In low and middle income countries, or any low resource environment, the focus should be on practical, low-cost, high-impact interventions. Leverage community-based rehabilitation and the skills of trained primary care providers or community health workers. Prioritize education, exercise, and self-management. These can be delivered without expensive equipment. Use group-based physical therapy programs in community spaces to reach more people at once. Provide culturally adapted educational materials using plain language, visuals, local languages to improve understanding and engagement. Promote non-pharmacological strategies to reduce dependency on medications and avoid unnecessary costs. Low back pain is a major public health challenge that needs a person-centered, evidence-based approach. The most effective strategies, education, exercise, and basic psychological support, are often the simplest and can be adapted to almost any setting, including those with limited resources. Interventions requiring specialized equipment or training can be included only where resources allow, but they are not the foundation of care. We should avoid interventions that are unnecessary, costly, or harmful, and instead focus on empowering patients with knowledge, skills, and community support. By aligning our practice with WHO guidelines, we can improve care quality, reduce health disparities, and make better use of the resources we have, ultimately helping more people live fuller, healthier lives.
Bueno, pues recordar un poco las palabras que nos ha dicho acerca del manejo, ¿no? Es decir, son datos que nos aporta ella desde la evidencia y qué es lo que realmente está funcionando para el manejo del dolor lumbar, ¿no? Se trata de, sobre todo,
or
con un
low
enfoque
back
de
pain,
ejercicio
particularly
físico,
on an
de
approach
colocos
of
y
physical
posiciones sanitarias,
exercise,
que eso realmente apoyen
interventions,
en el
and
automanejo de
of
la propia
course,
persona que
this
sufre
is
dolor
gonna
lumbar
help
para
people that are
mejorar a lo largo
suffering
del tiempo.
chronic pain
Bueno, pues
to
a
improve
continuación
throughout time.
vamos a escuchar a
So up
Silvano Muir.
next, we're gonna
Él es científico
hear
consejero del
Silvano
Centro
Muir.
Colaborador de la
He
OMS,
is a
Instituto de Investigación y
scientist
Rehabilitación y
of
Discapacidad
the WHO
de la
Collaborated
Universidad de
Center
Sciences
on
Barajas,
Rehabilitation and
y nos va a
Musculoskeletal
hablar
Health
Silvano
at the
de los
Institute for
desafíos de
Disability and
intervenciones de
Rehabilitation
rehabilitación
Research, and he's
concretamente
gonna
para el
talk
manejo del dolor lumbar.
about package
Adelante,
for
Silvano, te escuchamos.
low back pain. Silvano, go ahead.
Hello, I'm Silvano Muir, a senior scientist at the WHO Collaborating
Hola,
Center
yo
for
soy Silvano.
Rehabilitation and Musculoskeletal Health at the Institute for Disability and Rehabilitation Research, Ontario Tech University. In this section, we will briefly review the WHO Package of Interventions for Rehabilitation, Module 2. This is a well laid out quick reference guide that accompanies the WHO guideline reviewed by Dr. Cancelliere. It provides a summary of interventions by outcomes and equipment, tools, and providers that are required. As we have heard, people experience chronic low back pain commonly present in pain or with a loss of functioning.
Once important information about the condition is obtained and an assessment completed, then, with the patient's input, a set of goals for rehabilitation are created. Considering your specific setting, health system, and available resources, there is a suite of evidence-based interventions available. Selected interventions should engage and empower the patient, and when necessary, their families and communities. When selecting interventions, start with the least invasive and potentially less harmful. A great place to start is providing information and advice while emphasizing patient self-management. Patient information packages should acknowledge the patient's pain and limitations, highlight the probable low risk of serious underlying disease, and the likelihood of recurrences of most low back pain. Consider including advice on self-directed exercises and walking programs, and when necessary, use of mobility-assisted devices. Information is low cost and takes minimal to moderate time to deliver. It can be presented as paper handouts or brochures, a link to a YouTube video, or a respected website. Another benefit is that it can be delivered by different healthcare providers while optimizing patient engagement and empowerment. There are a number of different interventions that can be used to target relief or management of pain. Medications such as oral non-steroidal anti-inflammatory drugs take little time to prescribe but require prescription from a nurse or physician. Manual treatments, including spinal manipulation or joint mobilization, take minimal time but require experienced therapists, such as chiropractors and physiotherapists. It requires special treatment tables. However, a medical examination bench or a bench may be used along with pillows and towels. Structured exercises can also impact pain. These can be delivered at the individual or group level. At the group level, they help with compliance and social engagement, especially for older adults. Depending upon the patient's needs and goals, different equipment will be needed, such as timers, mats, resistive bands, and cycles. But in the absence of such equipment, creative use of locally available tools, instruments, or common objects that are easily accessible to any patient can be useful. This is particularly important since not one type of exercise is better than another. Structured exercises do require moderate amount of time and need to be guided by an appropriately trained therapist. One beneficial intervention in managing pain that requires more time and delivered by trained mental health workers is cognitive behavioral therapy, or CBT. CBT includes different strategies that focus on reducing pain by modifying physical sensation, catastrophic thinking, and unhelpful behaviors. Interventions can be used to impact functioning, including capacity and/or fitness. Depending on your rehabilitation goals, different interventions or activities can be provided based on availability of equipment or local setting. For example, walking on a treadmill or outdoors, or climbing stairs with varying inclines or slopes and speeds can help to build capacity. Recent study published in The Lancet by PAHO et al. Reported that a program of regular individualized progressive walking for 30 minutes per day, 5 times a week, and education significantly reduced low back pain recurrence by almost 50% and improved mood, sleep, and quality of life compared to a no treatment control. An effective and cost-effective intervention accessible to all. Fitness can be addressed by using weights, such as free weights or simple household items of varying weights, resistive bands, and exercise balls. Timers, a watch, a clock, heart monitors, or taking one's pulse, and ergometers or distant measurement tools can be used to assess outcomes. When addressing matters of activities of daily living, household or related utensils or equipment can be used or improvised to simulate specific activities. Such interventions take about 30 minutes and are provided by different trained therapists. Don't forget to consider work-related factors that may contribute to or aggravate low back pain. After an appropriate vocational assessment, vocational counseling and support may be required. Use work-related tools and equipment to illustrate lifting or work activities. This does take time and usually done by occupational qualified counselors. Finally, consider secondary conditions that are often associated with low back pain, specifically mental health. Managing mental health can be done by using different interventions, from oral antidepressants to psychological therapy to encouraging physical activities. Some of these therapies do take time and are delivered by specialists, medical practitioners, or psychologists. And for more information, check the reference materials that we have cited in this talk.
Muchísimas gracias, Silvano. He
Thank you,
leído en el chat
Silvano. I
que
am reading in the
efectivamente hay
chat
documentos
box
que se han mencionado, tanto
that
sobre la
maybe
canciller como sobre la UNED.
if the documents
Esos
that
documentos se pueden compartir
Ms.
en el momento
Cancelier and Silvano
del
Muir
registro para
have
participar
discussed this,
en
but
este
these documents
webinario.
have been shared at the
Dejadme que
moment that you have
busque
been
en la
registered
página
in
web.
this webinar, and this is available in our
Realmente es muy
website.
significativo lo que nos
So
comenta Silvano acerca del
everything that
manejo de la conectividad
Silvano
y cómo con
discussed is quite
intervenciones sencillas
meaningful.
que pueden iniciarse, por
With
ejemplo, con
some
caminar 30
intervention,
minutos al día
we could
o hacer, por
walk
ejemplo,
30
yoga o
minutes a
natación, como
day,
también ha
or
pedido
doing
Alexandra,
yoga,
y un buen manejo también
swimming.
a nivel de salud mental, ¿no?
All
Que
of
muchas
this
veces
could be
mantiene la
managed
salud
in
mental y evitar
mental health.
problemas
It
derivados
is
de
important
depresión, de
to
ansiedad,
manage
de estos
mental
procesos que
health to
pueden generar,
avoid
como hemos
pressure.
comentado a la larga,
And
problemas
as
también de salud mental.
mentioned, it
Vamos a
could
escuchar ahora
generate
el testimonio
back
de
pain
una
as well.
persona, precisamente
We're
de
going to
una persona
hear
indígena que vive en un entorno
the
de
testimony
difícil
of
acceso
an
a
indigenous
tratamientos y
community member.
quimioterapias, que ella hace
Sometimes
también
she is not
reflejo
available
la
to receive this
importancia
type of
de
therapy,
abordar las
but this
necesidades
reflects the
de toda
importance
la
of tackling
población
the
y
needs
no
of
solo
all
del caso de ella
populations
de
and not
que
only
vive pues,
of those
cerca o
that
rodeada de grandes
live
hospitales o de centros
around
de salud.
the hospitals.
Adelante.
Let's go ahead.
Our community is, like I said, our cost of living is so high. Our access to healthcare system is not the same as the where you guys are living. It's beyond declining to what you guys have access to. It's just not me that I go through this. All of us go through this in our community. It's just, I'm just not a one person talking, but I'm just talking on behalf of the whole community that it's affecting. And it's really affecting all the people of Cross Lake. With your back pain, with your chronic pain, it creates your mood changes. You're depressed, you're angry because you can't do anything, and there's you get mad at yourself, and why did you do that? Why did you end up like that? And you're not supposed to, it leads to depression as well, and stuff like that on me as well, because I was missing lots of work. And not just me too, but the other person I work with is got back pain and she can't really do much at work as well. And I have to do work for her, and now I have my back hurts. It's been our work has been decreased because of our back pains. Understand that it's just not a back pain, it's your whole body that's affected. Mentally, physically, spiritually, everything's affected when you have back pain. And it's just not that it's just not a one thing kind of thing. It's everything. Everything's affected. I hope they understand that part.
Bueno, fijaros cómo con este testimonio se viene a reflejar lo que se ha
So,
comentado
as
anteriormente,
you
cómo
can
ese
see,
pensamiento catastrófico
we have all
puede
of
llegar a
these
bloquear, ¿no?
catastrophic
El pensar
thoughts
que el
that
movernos no
could
va a ser
block
beneficioso para nosotros, ¿no?
our
Entonces vemos ahí,
ideas. And we could see that this is a classic example. And we're gonna have the participation of Melissa Atkinson. She's from Ontario Tech. She is a coordinator and scientist at the WHO Collaborating Center for Rehabilitation and Musculoskeletal Health and the Institute for Disability and
Hello,
Rehabilitation
I'm Melissa
Research
Atkinson Graham,
at Ontario
coordinator
Tech
and
University.
scientist at the WHO
Hola, yo soy
Collaborating
Melissa
Center for
Atkinson
Rehabilitation
Graham,
and
coordinadora y
Musculoskeletal Health
científica
at the Institute for
en el
Disability and
Centro de
Rehabilitation,
Colaboración para
Ontario
la
Tech
Rehabilitación y
University.
Salud Musculoesquelética en el Instituto de Investigación de Discapacidad y Rehabilitación en Ontario Tech.
As we have previously discussed in this webinar, the WHO guideline for non-surgical management of chronic primary low back pain in adults in primary and community care settings, and the package of interventions for rehabilitation, Module 2, musculoskeletal conditions, represent two valuable evidence-based resources for supporting persons with chronic low back pain. The WHO guidelines can provide an overall approach to developing a plan of management. It outlines 5 classes of interventions: standardized and structured education, physical interventions, psychological interventions, medicines, and multi-component interventions. When providing support or treating people with chronic low back pain, we suggest using the following guiding principles. First, take a holistic, person-centered approach to understand the unique social, contextual, psychological, and economic factors that may play a role in a person's pain. Understanding this context will also help you make decisions about a plan of management that is most appropriate for that person. Second, recall that adults seeking care for chronic primary low back pain should be offered evidence-based care that starts with the least invasive and least potentially harmful interventions, recognizing that this may vary across individuals. Finally, some people with chronic primary low back pain may require more than one intervention to experience benefit. This is referred to as multimodal or integrative care. Consider if the person you are treating would benefit from a multimodal approach. Reflecting on what Muriel shared about her low back pain, we can combine the WHO tools to develop a holistic and person-centered approach for her based on evidence. With Muriel, we would want to first validate her pain. She has described that every aspect of her life has been affected by back pain. We want to validate her pain experience and provide reassuring and empowering messages. We can educate her that reoccurrences or flares in chronic primary low back pain are normal and that there are many strategies to support her pain. We also want to better understand how back pain is affecting her mood, her functioning, and her work activities. Understanding and empathizing with her will help to identify appropriate interventions. Let's say that through conversation, we learn that low back pain is making it difficult for her to complete lifting tasks at work, and it's affecting her ability to go on her daily walks. We also learn that she has tried a short course of non-steroidal anti-inflammatory drugs and has not found those to be helpful. Muriel lives in a low-resource setting in remote Canada in a Cree First Nations community. She does not have access to rehabilitation services such as physical therapy or manual therapy in her community. Using the WHO tools, we can create a treatment approach that could be provided by a physician or a nurse or another regulated healthcare worker. To start, we want to provide her with educational resources, whether a printout or a YouTube video, on things like proper lifting mechanics. We can also provide her with resources on breathing exercises, such as box breathing, that can help with the feelings of stress that she experiences secondary to her back pain. Because we learned that walking is important to her mental health, we can provide her with information on the principle of graded exposure. We would advise her to reduce the distance that she is walking to a range that does not trigger her symptoms, and to work within this range until the symptoms of her flare decrease. Finally, we would want to schedule a follow-up appointment to see how the exercises, breathing activities, and modified walking distances are helping Muriel. We hope this example approach helps to illustrate how the WHO tools can be used to develop a treatment plan for an adult with chronic primary low back pain that can be tailored to their unique needs and adapted to both their and your unique practice environments. We hope that our webinar today has provided you with a perspective on why we should care about low back pain and how you can apply WHO tools to support the rehabilitation needs of people with low back pain. On behalf of the WHO Collaborating Center for Rehabilitation and Musculoskeletal Health, we would like to extend our thanks to the organizations who contribute to our work. Thank you.
Bueno, pues muchísimas gracias, Melissa, por
Well,
esos comentarios.
thank you, Melissa, for the comments and your knowledge. Now we're gonna hear two different perspectives. We're gonna hear the perspective of a professional or rehabilitation on how to tackle back pain, and then we're gonna hear perspective of a person that has suffered back pain, and she wants to share how this pain has been taken care of from the first level of care.
The support we need would be the establishment of an actual training program in the country. So in essence, more trained professionals able to deal with the complex care needs and multidisciplinary care needs of the patient with low back pain. We would have to look at using more community partners, whether that is care extenders or having more community-based professionals assisting us in the management for especially long-term low back pain patients. We would have to use more tools that support shared decision-making and triage algorithms to be able to get patients at the different phases and stages, acute, subacute, chronic, and triage them properly. More culturally relevant education materials as far as the different demographics we have within the country, and investment in technology and tele-rehab to use it to its most effective care and management, and an integration and implementation of rehabilitation professionals in the primary care model so that we get patients at their level of acuity before it becomes a chronic condition that becomes more costly. Getting patients early into the triage process to be able to decide if their significance of injury with regards to acuity. What that means is whether they're in an acute phase, a subacute phase, or a chronic phase, and guiding them appropriately to the care options. In addition to access to the care options, currently we would have already spoken about the staffing issues we have as far as the supply of professionals. So being able to get them in the facility without them having to be challenged at the acute care period with getting the care management. The location. Patients on the family islands do not have the same access to the professionals as those persons in New Providence. Awareness of their particular condition, understanding of what low back pain is, as far as the non-pharmaceutical, non-surgical options that are available, and actually generally the pain experience, as in what is the expected sequelae for low back pain, at least the first incidence. Also unmet needs as far as the biopsychosocial approach for patients, as in how their psychology, their social status in relation to where they live, the impacts of their environment, stressors, work, their general health influences their perceptions of pain. And community. There aren't enough options available in the community for those persons to be able to say, have care management where they live. The services can be improved by a stronger integration of physiotherapy rehabilitation practices in the primary care model, and looking at establishing and strengthening referral pathways depending upon the patient's acuity level or their particular condition across the entire primary care system. We can also look at early screenings and triage, more efficient and effective. Looking also to decentralize some of the care, having patients assume a bit more of a responsibility with regards to their early care management when understanding the disease process of first-time low back pain. We can look at integration of more tele-rehab and digital tools for clients and exhausting those possibilities with patients and persons with low back pain. Public education, again, as it relates to the condition, the options available, patient responsibility, because the patient is a part of person-centered and patient-centered care, to understand their individual role and responsibilities in their own care and management and adopting that as a priority. We can look at more culturally relevant resource material for all the demographic or the major demographic populations that frequent our services. We can look at, again, increased staffing and training for the staff within the system and use of untrained staff to assist as care extenders within the facilities to assist in giving the patients care and management.
Bueno, pues pasamos ahora a escuchar el testimonio, como hemos comentado
Okay, we will
anteriormente,
continue with
de
the
otra persona que también sufre de dolor lumbar.
testimony of a new person that has low back pain, and we have collaboration of the Center of Health in Chile through a biopsychosocial aspect. We are gonna be discussing the following.
Low back pain is one of the leading causes of disability worldwide. In Latin America, it most frequently affects women between 50 and 55 years of age, and it causes strain from economic factors, overweight, work-related conditions, stress, sedentary life, among others. In Puerto Varas, in Chile, a multidisciplinary strategy has been implemented, demonstrating that with a comprehensive approach, recovery is possible. In April 2024, a user access plan in Puerto Varas began treatment for lower back pain. Care was based on a biopsychosocial model integrating nutrition, mental health, physical activity, medical care, and kinesiology. This year, severe pain started in my lower back, so severe that I had to go to the emergency room. There, the doctor saw me, diagnosed me with lumbago, and I had to get an injection for the pain. I was on treatment for about a week. I then made an appointment with the doctor, also from the city's health service, and she immediately ordered several tests to me. As for kinesiology, the truth is that it was the key. Session after session, I miraculously improved in mobility, flexibility, and also in pain relief. Through the Family Health Center here in the city, I learned about the Healthy Life program, which was very transformative for me. It's a program that not only focuses on physical training, but also includes nutrition and psychological counseling. All aspects of this treatment have been closely interrelated. From the nutritional aspect, for example, which has helped me eat more consciously, to the psychological aspect, which has helped me manage my emotions and prioritize self-care, and also, of course, all the physical activity. Right now, I feel completely liberated. All my psychological and physical improvements make me feel more energetic, more functional, and with a better attitude every day. All this is incredibly important, and I value that a lot, especially with my family and having quality time for my daughter and being a better person for her. The success of this treatment was possible thanks to Puerto Varas comprehensive health care, nutrition, physical activity, psychological support, medical care, and physical therapy. Teamwork, strengthening mind, body, and community. In Salud Puerto Varas, we bring health to our community.
Bueno, pues,
well,
muchísimas gracias.
Thank you very much to our colleagues from PAHO in Chile for this communication.
Tenemos aquí ahora
We have
veis abajo un cuadrito para poner vuestras preguntas.
the Q&A section here. You can ask questions and make comments. We have a first question for our team of Ontario Tech. I'll translate it into English.
So pelvic pyramid syndrome, the piriform syndrome, has been considered as a low back pain, and how can this syndrome can be addressed?
The syndrome, you could put it together with many other mechanical conditions that relate to back pain, can be addressed in the same manner that we have recommended for other conditions. And that would include the stretching, or first assessing the problem and then dealing with what you find on your examination and assessment. And then accordingly providing appropriate physical activities and stretching exercises to try to deal with the condition.
Muchísimas gracias.
Thank you very much, Silvano. In fact, low back pain includes a number of conditions and syndromes, including this pyramidal syndrome, which shows a very similar pathology to LBP. And what Silvano said was therapeutic exercise, physical exercise, following formerly proposed recommendations. We have another question here.
So have we considered the evaluation tools to address low back pain?
Gustavo, can you be a little bit, can you be more specific by what is meant by evaluation tools? Are we talking about clinical tests? Are we talking about disability scales? All of the above.
So para la persona que ha escrito esa pregunta, si puede ser un poquito más exhaustiva.
So if the person who wrote that question needs to know more specificity.
How long should we focus on education activities, and how could we measure the impact of these education activities? So I'll repeat the question. In patients with chronic low back pain, how long should we dedicate to this intervention, to these education interventions, and how can we measure the impact? From Santiago Gomez Arguello.
I think that that starts right away, and how long that should go until the patient understands what is required, the self-management strategies, they understand the prognosis of the chronic low back pain in their specific case. And how is that measured is self-reported, a continuous check-in with the patient to see how they're doing, if what they are being educated on and some of the self-management strategies are helping, if they're sufficient, or if additional intervention is needed.
Thank you very much, Carol. Espero que esta respuesta haya abordado la pregunta. Tenemos aquí una pregunta en inglés muy interesante.
Thank you very much, Carol. We have a very interesting question in English.
Neuropsychology perspective, chronic pain involves not only physical impairment, but also central nervous system sensitization, linked to emotional and cognitive factors. And the question is, how could psychosocial and brain retraining approaches be integrated into the WHO recommended primary care protocols for chronic low back pain management while maintaining biomedical consistency and evidence-based practice? So basically, it's integrating this psychosocial intervention in the primary level of care, I would say. This is the question.
So this is often essential in patients with chronic low back pain, that, as the question refers to, that the psychological aspect be considered. And if we refer to what has been presented as evidence, cognitive behavioral therapy is really a good tool to assist patients in coping, in adapting their activities to their pain. So the purpose of the intervention, especially when we deal with plasticity, is that it's not necessarily to cure the patient from the chronic pain, but rather to assist them in managing their daily activities, their work, their family responsibilities, and so on. So the coping aspect of the psychological interventions are really the focus of these interventions.
Thank you. Thank you very much, Pierre. And we will go for the last question. I think this is a really interesting one. Can we use the WHO packages for herniated disc? So when we have an hernia in the low back pain, can we use the WHO guidelines? This is a really good question.
I don't see why we can't. Again, herniation is another, another part of the condition of low back pain. The question is, how is the patient presenting? Are there neurological conditions that require, there are red flags that require immediate attention? And those would be redirected to the appropriate healthcare provider. Otherwise, managing patients with disc herniations or chronic back pain can use the guidelines that are and suggestions that have been presented through the WHO and effectively manage these patients.
Muchísimas gracias, Silvano, por tu respuesta. Efectivamente, pues es frecuente
Thank you
que
very
todas las
much,
personas
Silvana, for your
mayores
answers.
tengan
Frequently, beyond 45 or 50, people usually present herniation, and if there are no symptoms with red flags, we can apply all this clinical practice guideline recommended and the WHO. We don't have much more time for questions, but there are more questions, many interesting questions relating low back pain with other kinds of pains and pathology, prostate pain, for example. So thank you very much for all those who have been with us and have devoted time to this webinar. I hope this has been useful. Thank you very much to all of our colleagues in Ontario University, Melissa, Silvano, Pierre, and Carol, for your deep scientific knowledge and for shedding light on how to treat low back pain. Thank you very much. This video will be in the rehabilitation website at PAHO. I hope sincerely it has been useful. Thank you very much. I greet you all.